So we saved the best for last, return on investment. Show me the money. Glen Mays probably doesn't need an introduction since he's kind of written the book recently on calculating return on investment in public health, but I'll give you a short bio anyway. He is currently with the University of Kentucky College of Public Health. He was there a couple of years ago, right, Glenn? Yeah, serves as the F. Douglas Scutchfield Endowed Professor of Health Services and Systems Research there. His research focuses on strategies for organizing and financing public health services, preventive care, chronic disease management for underserved populations. There was discussion at dinner that we need more economists in public health. Dr. Mays is an economist in public health, and he has an interesting story, which he probably won't get into, about earlier elders cautioning him not to go into public health because that just wasn't the place to go if you were an up-and-coming economist. But he bucked the trend and did it anyway. Currently, he directs the Public Health Practice-Based Research Networks program funded by the Robert Wood Johnson Foundation, which brings together public health agencies and researchers from around the nation to study innovations in public health practice. So please welcome Glen Mays.
Thank you so much for letting me join you today, and very interesting. I wasn't with you yesterday, but just hearing the issues and the conversation this morning. Obviously, we're continue to be in a challenging set of circumstances in public health, and these issues of being able to understand, to document, estimate the value of what we do in public health is perhaps never been more important than it is today in engaging on the political side of the equation, but also in just making good decisions within our own enterprise of public health. This information very, very important. And yeah, I forgot about that, Carl. The story I told about how I ended up in public health. But I did come out of the health economics training program at UNC Chapel Hill, and had already early in my graduate program had developed an interest in public health, and that was supported by many faculty. But the economists on our faculty thought, Glenn, why do you want to study public health? It's economically uninteresting, field of study. And they were thinking about just looking at healthcare expenditures and so many other major cost drivers in the system. Public health just gets that tiny share. And I think that's not the way to think about it from an economic perspective. Think about the enormous costs that our society are there because we're chronically underinvesting in public health and prevention. And that's the real economically interesting way to think about these issues in public health. And that's really fundamentally that issue of gets at the heart of what we try to do in supporting return on investment kind of studies in the public health world, understanding the value and the economic consequences of what we do or what we fail to do in public health. So I'm going to give you some updates on kind of where this field of this body of work, ROI, public health, economic evaluation of public health work is going. Talk a little bit about some of the work that's underway and a quick tour of some of the things we're beginning to learn, and then hopefully also attract your interest in some of the things that are on the horizon in this area. I should say at the outset, much of the work that I do in this field right now, and that my team at the University of Kentucky is doing is supported by the Robert Johnson Foundation. They fund our Center for Public Health Services and Systems Research at the University of Kentucky, where a lot of our work is happening in this area. Want to acknowledge that. In this crowd, I probably don't have to make much of a case for why this is important, why these kind of studies and estimates are important. Fundamentally, they're about helping us understand the outcomes that we're producing through the public health enterprise. Do do those outcomes justify what we spend on them? And also really helping, this is kind of helping to inform when we have new investments, if there is a new dollar, where should it be directed to achieve its greatest impact? Obviously, the conversation today, we don't have many of those opportunities currently to think about new investments, but you can also think about the reverse of that as well. This kind of research can help us. Cuts have to be made. Where will they do the least harm from this perspective? And as well as helping us address these related questions of value, fundamentally, how much health can we produce through the kinds of investments we're making in the public health enterprise? And in particular, this issue, the second issue came up already this morning in conversations, helping us understand the effect of what we do in public health on the larger healthcare system, and given the overriding concern with long-run medical cost growth, and we know this is the primary problem as we think about long-run deficits and debt and reining in that problem. Healthcare cost growth is the biggest part of that long-run problem. Can public health be part of that solution, and how do we get firmer estimates of that so that we can again help to communicate the value of public health from that perspective, helping us address some of our larger health system problems. And as you probably know, there's still a lot of uncertainty and controversy around these issues. These are some kind of headlines I snatched from just a couple of years ago, reflecting just the media coverage on some of these issues. These came out kind of during the final months of conversations around the Affordable Care Act and the issue of creating the Prevention and Public Health Fund, and showing that there's still a lot of uncertainty about whether investing in public health, investing in prevention, actually has firm economic payoffs. And so, again, obviously there are lots of stakeholders that we deal with that are not convinced of this. And so, part of that is we don't have nearly the breadth of the evidence base that we need yet on this topic. So that's the reason why we need to continue to build this body of research and body of applied analysis and explanation around ROI. There was a recent Institute of Medicine report that came out toward the end of last year that if you haven't seen this, I would definitely recommend reading. I say that not only because I was on the committee that helped to write it, but I think it does make some important recommendations specifically on this topic. This is a report that came out on for the public health investing in a healthier future. Really, the entire report deals with the issues of public health financing and funding, and it makes a number of recommendations for kind of shoring up our financing system for public health. But in doing so, it also recommends that we need a stronger evidence base around ROI and understanding the health and economic impact of investments in the public health system. And these are, I think there are a total of 12 recommendations in that report. These are 4 of them that I think are particularly relevant for this group and particularly relevant for again, thinking about ROI and cost studies in general in public health. First of all, recommended that we needed to identify a minimum package of public health services, and that can be nationally agreed upon that this is the minimum package of services that every state and locality should be delivering. We need to figure out and reach agreement on not just what's in that delivering categorical programs, but also the cost of that's required to invest in those foundational capabilities or core infrastructure. It makes some recommendations around allowing greater flexibility in how state and localities can use their federal funds. It makes a recommendation for actually creating a national chart of accounts that will enhance our ability to track spending levels and flow of funds nationally to get a stronger, firmer picture of public health spending across the country, government public health spending. That importantly would make doing these kind of studies, ROI studies, much easier to do and much more feasible. And finally, makes a strong recommendation around expanding research and analysis on costs and on the effects of public health delivery, including these kind of ROI studies. So this is another this report has been another driving force behind making progress on this front. We know that there's one reason why we don't have more evidence than we do, and there's not more ROI studies out there than there are, is it's challenging to do. It's challenging to do ROI in public health. There's obviously unique aspects of public health delivery and governmental public health delivery that make these studies challenging. The time lag that's there for many of the more prevention-oriented services that we deliver between when we invest and when we actually see effects or benefits or returns from that poses challenges to doing these kind of studies. Obviously, we have to account for the time, cost of money, and that as part of that time lag. But just being able to estimate downstream benefits, particularly for prevention-oriented, chronic disease prevention-oriented programs and services, is challenging. We've got that 10-year window that at least the Congressional Budget Office insists on using in terms of only looking at benefits over a 10-year analytic horizon. The CBO is not going to consider any benefits outside of that horizon to see what that's part of this timeline challenge as well. The whole issue of distribution of costs and benefits, who pays versus who realizes the returns, is challenging. I think as we learn how to deal with this distribution issue better, that this actually becomes a real, I think, an opportunity for us. We can show again that that the things that we pay for in public health have spillover effects onto Medicaid, as we talked about earlier, or onto other sectors of the economy. That having that kind of evidence can obviously be really powerful in the current environment, making the case for public health. But actually coming up with that evidence, tracking those distribution of benefits to sectors outside and to stakeholders outside of public health is challenging. Fundamentally, it boils down to measurement, being able to measure, having good, reliable measures of costs, and being able to generate strong, reliable estimates of the benefits. That requires good information systems, and including the information systems that you all manage and develop your financial systems. And so we collectively need to think more about how we can better use of the information you're currently sitting on and maintaining, but also thinking about going forward, how might we modify and expand upon the financial information systems that states and their partners at the local level in particular maintain to make it easier to do these kind of studies. And then there's the issue of attribution. How can we be sure that the benefits or the returns that we realize are actually attributable to what we did in public health and not to other things? This is more of a research design kind of an issue, and I think also makes the case that for some of these kind of studies, we need to be working in partnership with our colleagues in the research settings who can, in some cases, bring stronger research designs to bear when it's important for us to really make a strong case about attribution, being able to wash out or to rule out other explanations for why we see a change or a trend in health or a trend in an economic outcome of interest. So the key ingredients, and again, I think that this audience knows as well, we need to be able to estimate and have reliable information on costs, what we spend, return and put a value, put an economic or financial value on those returns. That may be valuing the outputs that we're delivering, the actual services that are being delivered in public health, or we may actually try through some of these studies to value outcomes, including health outcomes that are attributable to public health interventions. And so, depending on what our target is on the return side of this equation, analysis, this can involve, this can drive decisions about time frame and also decisions about the kind of analysis and the kind of research design that we might have to put into place for these kind of studies. I also think it's important when doing these kind of studies to manage expectations. Again, with some of the audiences that use this information. We often with ROI analyses, we'd like to be able to show cost savings, and there certainly are many activities that we do in public health, many projects that can reasonably be expected to produce cost savings. But in general, that's a pretty high bar. When we look at overall the kinds of ROI studies that we do and economic studies that we do within the health system overall, often a more reasonable expectation is an expectation around cost effectiveness. We want to be able to show that there is good value, good economic value for the dollars that we spent on an activity. If we actually produce net cost savings, that's even better. But at a minimum, we want to be able to show value from a cost effectiveness standpoint, that our investments have been effective because the value of the results they produce are commensurate with what we had to spend to generate those results. And so cost effectiveness analysis often will involve comparing, making comparisons of a project to other ways perhaps other ways that those dollars could have been spent, other possible investments. So that's something to think about. Some of the key considerations that we have to deal with in doing these studies. First and foremost, thinking about from whose perspective are we going to analyze ROI. Again, part of this is thinking about who bears the cost. Some of our studies, and for this audience, you may be particularly interested in analyzing ROI from your state health agency's perspective. But again, to make the case and to inform federal decision making, it may be important to expand that to include the federal perspective, or to look to use an even broader perspective in terms of looking at cost and benefits for the health system at large, or for society at large. So being strategic, it's important to be strategic and deliberate in deciding this issue of perspective. From whose perspective are we going to carry out analysis? Thinking about the time horizon in terms of that lag between investments and when we expect to see outcomes. How long are we going to? How far downstream are we going to look to measure returns from these studies? And then thinking about the actual types of interventions or types of public health actions that will be the focus of ROI studies. Many of the existing, I'll show you some examples of many of the existing studies that we have, ROI studies in public health, tend to focus on specific categorical public health programs. In part because it's obviously important to have good ROI and good economic data on those programs. But I think increasingly there's an interest and a need to also expand the horizon of ROI work and start to focus on not just programs we're delivering, but also being able to document the value of the larger investments made in public health infrastructure and that cross-cutting infrastructure that supports potentially a broad range of public health activities, investments in surveillance systems, for example, and in other kinds of infrastructure that are economic analysis data is most lacking when it comes to really looking at the ROI of investing in these kind of cross-cutting public health infrastructure activities. So that's in part where some of this work in the field is increasingly trying to go. Doing ROI around the kinds of projects being supported by the CDC's National Public Health Improvement Initiative, for example, which in many cases those are cross-cutting kind of quality improvement or infrastructure development programs. Very, very important if we want to see continued investments made in programs like NIPI that are not necessarily categorical in nature. Important to think about these issues of both direct costs of what we do in public health, the actual cost of implementing something, a program or an activity or a project, but also to think about the indirect costs. And this is often where it's particularly challenging to do studies to value the effects of, for example, productivity gains or losses that are realized as a result of delivering public health programs or services, lost time from work or school, valuing those, the time costs that come into play, the value of interventions that actually save time in delivering services, those kind of indirect costs often can be a major part of the overall economic value of public health activity, but very, very challenging to measure and estimate. So that issue of indirect costs becomes a big area of focus, an important area of focus for these kind of studies. When we think about the return side of the equation or the benefit side of the equation, these are some of the major kind of streams of returns that we think about in applying ROI analysis to public health. Gains in efficiency for things that we do that actually reduce labor costs, reduce material costs. Those are efficiencies in the production or delivery of public health services that can be a very important part of the value stream of a public health activity or program. Often those kind of efficiency gains we measure them, we capture them in the cost measures that are produced through an ROI analysis. But we can also have productivity gains as well. If we actually if we implement a program or a service that allows us to deliver more services or to reach more people, detect more cases of disease, or to reduce the cycle time, reduce the time that it takes to follow up to do a disease investigation. Those kinds of effects would show up in an ROI analysis in terms of productivity gains, and we have to have a methodology of valuing those gains, putting an economic value on those kind of gains. Other programs, services, or activities that would be subject to an ROI analysis may actually produce enhanced revenue. And so we're certainly seeing some of those kind of projects taking place across public health agencies these days with efforts to expand billing, for example, or again to expand the reach of public health programs, billable, fee-generating public health programs. And so those returns would be reflected in financial measures that would be part of studies. And then the fourth area, which tends to be the toughest area to incorporate into ROI analysis, relates to health gains, actual impact on health that our public health programs may have. And these typically require us to have good health outcome measures. So if we want to incorporate the economic returns associated with health improvements that are produced by public health programs, we have to have ways of first measuring these outcomes, like deaths averted or cases of disease prevented, or quality-adjusted life years gained, and then have a way of placing an economic value on those kind of outcomes. In terms of the analysis stage of the equation, these are some of the kinds of questions that are often of interest and desirable of seeking answers to. understanding where the break-even point is for an investment in a public health program or service. How long does it take for us to recoup the initial investment in a program or service? And then understanding issues of maintenance. How long do the benefits of investing in a public health activity last? And is it a one-time investment, or are there recurring costs, recurring investments that need to be made over time to realize the return? So these kinds of issues, typically with an ROI analysis, we can factor these into the analysis and being able to break these, answer these kind of questions with a well-designed ROI analysis. In public health, there are also a couple of other issues that often come into play, thinking about, again, the return side of the equation, valuing, putting an economic value on public health work. One relates to economies of scale. A lot of the work that we do in public health, some of the public health programs and interventions that we work with entail fixed costs, and activities with large fixed costs often will have this economy of scale quality to them. We actually can realize more value, more impact by spreading those fixed costs over a larger population size, a larger jurisdiction, a larger setting. And so being able to understand where those economies of scale come into play can be another important piece of an ROI study, particularly in looking at public health delivery at a local level and looking at differences perhaps in delivering differences in ROI across different local settings, rural versus urban, smaller versus larger jurisdictions, for example. And the related issue of economies of scale, for some of the kinds of public health programs and activities that we support and deliver, there can be efficiencies realized by using the same infrastructure, the same investment to support an array of related programs and services. So you're getting more bang for your buck, essentially, by investing in a public health nurse program that can deliver both maternal and child health services, as well as infectious disease control services. That one investment of labor, the returns on that can be larger if that investment is made in context of supporting multiple programs from that investment. Sometimes ROI studies aren't designed with that to look for that kind of synergy and look for that kind of efficiency. But I think we do ourselves and do public health as a service when we fail to recognize that kind of a value stream potentially, which I think exists in a lot of public health programs and services in particular. If we fail to recognize the possibility of economies of scope in doing an ROI analysis, we might underestimate the true value and the total ROI of the public health action that we're studying. So these are some important things to keep in mind. Let me give you a couple of examples. I'm going to step through these quickly and then talk about some of the new things on the horizon. So you can do these kind of studies at a number of different levels. Kind of macro level ROI studies, which I've done some work in this Trust for America's Health study that came out a couple years ago is a good example of that. Looking at kind of aggregate ROI from investments in public health at an aggregate level. And the Trust study, again, is used a lot and continues to be used a lot on the Hill in informing these kinds of questions about investments in public health. But basically, the Trust study shows that there's an ROI of about $5 to $6 for every $1 invested in public health over a 5-year period. That goes up even higher as you look out to longer time periods, 10 to 20-year time horizon. This was an example of a prospective study. So they used kind of a prospectively used simulation model to project the likely effects of new investments in the public health system over these different time frames at a macro level. At a more micro level, a program level ROI analysis, these are body of evidence around these programs. These estimates are profiled, for example, in CDC's Guide to Community Preventive Services, where there's good ROI or economic evaluation estimates. They'll be listed and cited in the community guide, for example. Another example, this is a study that just came out from the state of Washington, looking at program level analysis, looking at their comprehensive tobacco prevention and control program, showing this was a retrospective study, though, so they actually used data retrospectively on their state's tobacco program, looking at spending and then looking at the effect of that public health spending on largely on healthcare costs, healthcare savings in this study, where they had to show again about a $5 return, about a $5 savings in healthcare spending for every dollar invested in that program. And finally, we've done some work over time looking at local governmental public health spending that we've done in partnership with NACCHO. And this also was work that's retrospective in nature, so looking at taking advantage of data we have on local public health spending levels over time, and then associating those with outcomes, and in this case, looking at how spending affects health outcomes in terms of preventable death, preventable mortality over time. We were able to show a pretty strong connection between public health spending levels at the local level and then subsequent declines in preventable deaths before age 75 from potentially preventable conditions over a 15-year analytic horizon, 15-year time period that we use, 93 through 2008. So retrospectively using that data to estimate the health effect, which you see here, and then putting a monetary value on that health effect to get to an ROI calculation. We've also done more recently, using that same kind of retrospective ROI analysis, to associate levels of public health spending with medical care spending, to begin to start to answer this question of what is the spillover effect, or what is the offsetting effect of spending on public health that the public health investments have on subsequent medical care spending. We know this is an area, again, of large interest at the federal level, and an area where we frankly need a lot more evidence and data to show, again, spending on public health, investments in things like these, for instance, public health funds. What are the subsequent effects of that spending on the medical costs and medical care spending rates over time? Our preliminary work shows that there is at least over a 15-year, or in this case we use that same 15-year analytic horizon, a modest but significant offsetting effect of public health spending. Communities that spend more on public health over that 15-year period saw larger or saw smaller rates of growth in their medical care spending over that time.
Can you explain the medical cost offset?
Yeah, so that number, that number up there at the top, that medical cost offset, is actually our way of quantifying the magnitude of the effect that a dollar spent in public health has on downstream medical care spending. So that cost offset of about 0.9% basically says that if we were to increase public health spending by 10%, we would see about not quite a 1% reduction in medical care spending over that time. So it's a 10% increase in public health spending gets you about a 1% reduction in medical care spending over the
comparing to 3% and 9%.
Exactly. That sounds like a small number until you realize, per capita public health spending is a couple of $100 per capita. Medical care spending now is $8,000 per person. So they're very different scales. So that small number translates actually into a large economic effect, which we kind of summarize here. We take the health effects that we estimated and also take that medical care offset effect and use that to then show what average community in terms of the rate of medical care savings that is attributable to the level of spending in public health. So we use those estimates that I just showed you there quickly to then basically estimate what the effect would be in an average community. An average community that was able to increase its public health spending by 1.2%, which we based on, that's what we would have expected would occur under the original allocations in the Prevention and Public Health Fund. Over 10 years, that would cost the average community about $7.2 million in additional public health spending, but the medical cost offset, the savings from the medical care spending side, would be $6.3 million. And that's just looking at Medicare. The study we've done so far looks only at medical cost offsets in the Medicare program, because that right now that was our easiest source of data in terms of looking at medical care spending on a national level. So the average community, if you were to increase spending, public health spending by 1.2% over 10 years, that would cost us about $7.2 million. We get almost all that back. We get 90% of that back over 10 years just through savings in the Medicare program. Not even thinking about Medicaid savings or savings to private insurers. So we almost recoup our costs just in Medicare savings. Plus, we're actually saving lives. So we in this case, can roll that up into a cost-effectiveness ratio. The cost per life year gain in our analysis was $546. It takes again less than $600 to save an additional life year through investments in public health. So this is again an example of a macro level kind of ROI analysis, one that's trying to factor in both health effects as well as factor in this how public health is kind of spillover effects on issues of medical care spending over time. We need a lot more of these kind of studies, and need to get better and better in doing them. It's an example of the kind of work we can do in this field. Put our hearts and minds to it. There are a number of existing ROI tools that are out there already, many of them developed by CDC that tend to be in specific programmatic areas. There's a asthma ROI calculator that ARC has developed. It's available on the web. There's CDC's smoking ROI calculator that's been out for a number of years now. They more recently have produced an obesity ROI calculator. The Ronald Johnson Foundation has a diabetes self-management ROI calculator for calculating ROI from diabetes self-management programs. And there's even an ROI calculator that can be used to calculate ROI from investments in electronic health records. So these are some good tools. Until recently, there wasn't really a kind of a generic tool that was out there specifically designed for that could accommodate kind of ROI easily accommodate ROI studies across the landscape in public health delivery. But this is a project that ASTHO and CDC have been working on most recently. I've had the privilege of working with Carl and others at ASTHO to help develop at least a demonstration version of a kind of generic ROI calculation tool developed specifically for public health programs and public health activities. Still a work in progress, but we do have now an actively working demonstration version of an ROI tool that has been developed for public health. This is work that ASTHO has developed again with CDC through the National Public Health Improvement Initiative program. And so one of the major early focus of this tool is on estimating ROI for public health improvement projects, QI kinds of projects, and other kinds of improvement projects that are the kinds of things that states and local agencies are undertaking under the CDC-funded NIPI program. But we feel like it certainly has applications beyond just the QI quality improvement space into other areas of public health snapshot of that tool. Again, it's being in recent months. It's been through kind of a field testing process that ASTHO and Carl have led to actually test this tool out in some real-world public health settings with some real-world public health improvement projects, and understand how well it works and where some of the issues might be. We're still in the field, still seeing this tool tested. It's still pretty rough around the edges. Obviously, it's going to need to be iterated and improved over time. But I think what we have so far is a pretty good first foray into creating a resource like this that can be used, can take the concepts of ROI and make them easier to implement in a state or local public health practice setting. And so I know that Carl would be glad if folks have an interest in accessing this tool or making use of it. Carl's the one to talk to, and I think we are I think it's a pretty exciting effort underway. And it requires having some reasonable data to support ROI analysis, including having data on the operating costs for the setting that you're studying that you want to apply the ROI analysis to. Both ideally operating costs both before and after implementation of the project or strategy or program that you're estimating ROI on. So understanding, having data on operating costs, obviously is needed to carry out these kinds of studies. Having data on revenue, if that's relevant for the ROI application that you're looking at. And then it includes the ability to also measure and incorporate measures of outputs and services that potentially are part of that stream of value that can be incorporated into your ROI analysis. And it even includes a rather crude way right now, but it does include, this tool does have a way of actually incorporating measures of health and economic outcomes and factoring those into the ROI analysis as well. Ideally, in an ideal situation, you have those kind of measures both before and after implementation of the strategy or program that you're analyzing ROI for. So this tool, again, in terms of what kinds of returns are studied and analyzed here, these are the kinds of returns that this tool can accommodate at this stage. Again, looking at returns due to changes in operating costs, cost savings due to operating costs, looking at changes in output of service delivery, looking at changes in the time required to produce services or deliver programs, and then also it does have some capacity to incorporate changes in health-related outcomes into the ROI analysis as well. This will continue to be a work in progress, no doubt, and I hope that this tool will improve and get better over time. But I think it's one of the activities that's moving forward in the space now that I think has some real potential to help us do a better job with these kind of studies. In the interest of time, I think I'm going to skip through a couple of these slides and get to the end. I had a couple of slides here on just the cost, the issues of the cost analysis side of the equation, which is obviously very, very important and critical to doing an ROI study is having good data on cost. Rather than going through details here, I'm going to skip to the punchline, which is again a couple of other things that are happening in our environment now that that I think are going to be very helpful to us in moving forward with these kinds of studies. One is a project that NATIO has been leading for about a year now to improve the capture and analysis of cost It's being developed obviously with a kind of local public health setting in mind. Obviously, given that NACCHO is leading this up, but I think has some real potential as this effort grows to expand data sources for supporting ROI studies in public health. It's being launched largely as a voluntary initiative. It provides a way for local public health settings who want to do this kind of work can voluntarily submit their cost data into NACCHO's funds data system, and it will support a variety of kinds of things. It supports some kind of some enhanced financial analysis, financial ratio analysis in public health, but then also provides kind of a common way of classifying costs and in a way that can then support these kinds of studies, ROI studies in public health. So it's still fairly early in that program's implementation period, but I think it has a real potential to help us in do these studies going forward. Second initiative I want to share with you is one that we're actually launching this summer with the support of the Robert Johnson Foundation. We're launching it through our Public Health PBRN program, and that is an actual series of new studies that we're calling Public Health Delivery and Cost Studies. These are studies where we'll be funding through 12 of our public health practice-based research networks across the country. They're specifically designed to produce research quality data on the cost of delivering public health, core public health services, and to support analyses about what factors cause variation and change in the cost of delivering public health services. We're funding these studies specifically to again create a stronger evidence base on the cost side of the equation that we need to support ROI studies in public health. These are studies that will take some time. Most of them are either 12 or 18-month studies. Again, we'll look at a very granular level, endeavoring to measure cost of public health delivery and to compare those costs across different state and local public health delivery settings to help us understand more, again, from the cost side of the equation, what kind of factors are important in driving cost trends in public health. So I want to make sure you're aware of that. We have PBRNs now that are up and running. These are research networks that we sponsor through the foundation, up and running in 28 states now across the country. So many of you, there's actually a public health PBRN that's based in your state. I'd be glad to talk with you offline if you're interested in connecting with that group. But these networks will be implementing these cost studies starting this summer, and so we expect these to really be another force making ROI kinds of studies much easier to support in public health.
Could you just send us that list?
I sure will. In fact, I think my last slide. I've got a map of our PBRNs here. So here's where we have our PBRNs. Your state's colored in here. There is a public health PBRN operating in your state. And 12 of these are going to be funded to implement these delivery and cost studies. And actually, Carl and Katie both helped us with the review process on that just a couple of weeks ago. So those will be getting underway very shortly. The last thing, I know I'm out of town, but at a time, the last thing I want to mention is this. Last thing I want to mention is that I think a related initiative that is really going to help us push forward with these kinds of ROI studies is an effort that the Robert Johnson Foundation and CDC together are leading around developing a national chart of accounts in public health. I think this group, the CFO group, have talked about this concept over the last year or so. Again, it's one of those recommendations that was in the ILM report from last year. CDC and RWJ have convened now a work group to start thinking about what this kind of national chart of accounts should look like, to begin to develop some of the design principles and think about what a structure for a chart like this should be. That work group has been convened and met for the first time in April. ASTHO was well represented there. Paul Jarris was there. Got represented ASTHO and major representation on it. Representation from CDC, obviously, and several other HHS agencies. And so again, this effort is going to be challenging. It's not going to be easy, obviously, to implement a resource like this. But if successful, it's going to make doing these kind of studies much easier, much more feasible by providing comparable cost data in particular, and comparable financial data across states and across public health settings. So I wanted to make sure I know you've talked about this effort. I wanted to make sure you know it appears to be moving down the pathway and toward development at this stage. My group at Kentucky has actually been tasked. We've been asked by CDC. Janet Collins at CDC is one of the point people at CDC that's leading this effort. She's asked us to, as part of it, to inform the work group by actually preparing a white paper that would flesh out some of the design considerations around a national chart of accounts, and it would also flesh out some of the uses of a national chart of accounts, specifically around ROI and economic analysis in public health. So we're going to be, we've been given a very short time frame to develop this paper over the summer to help inform this work group as it moves on and does its work throughout the year. As part of that, we're going to be taking a close look at existing state public health chart of account systems and existing state financial information systems that might serve as good models for a national chart of account. And so we'd love, obviously, we're going to be connecting strong with ASTHO and our other partners in doing that. So if you've got a good model, if you're sitting on a model, a model that exists in your state that might be instructive for this work group in thinking about what a national chart of accounts might look like, we'd love to talk with you and love to take a closer look at your state level chart of accounts. Some states do have organized public health chart of account systems, and that could be very important models for a national effort like this. So we'll be doing that over the summer, and we'd love to connect with any of you who have an interest or maybe have a model you want to share with us on that. So I think that's all. That's all I have here. I think bottom line, why do we need to press on this? I think fundamentally, this kind of evidence, these kind of analyses are going to help us make the case that again, these investments are important, and we're seeing already the downside of not having more of this kind of evidence in the political discourse and in the administrative actions that are taking place across the country. So I think we've got some good resources that are developing, and there's a growing energy behind doing these kind of studies. But we can't do it without working with people like you and colleagues in the state and local health agencies. So thanks for letting me be here with you. My contact information here. If any of this stuff sounds like things you might want to have more information on, feel free to give me a call or shoot me an email. Glad to do that.
Thanks so much, Glenn. Really appreciate it. We do have some time for questions, and Glenn is probably the leading expert in ROI, so I'd encourage you to take advantage of that fact if you have any questions on ROI.
From Rhode Island. My question is more of a concern of how you're going to get a national chart of accounts. Most of us are subject to the state chart of accounts that we have to follow with our state controllers. I think when we talked about this on the phone at one of the telephone conferences, we suggested that the place to really go if you were serious about doing this is get the state controllers group, whatever that's called, together and try to see if they couldn't come up with something that's more, because we're basically slaves to them and we do whatever they tell us.
Yeah, that's a great point. That's something that I think this work group is going to have to grapple with, first and foremost in charting a path forward on that. I know that some of the conversations that have been had, and even I think some of the conversations that your group has had, identify this notion of thinking about that in terms of a translation table. It's not like this national chart of accounts is going to replace our existing state-level systems for tracking flow of funds at the state level. But I think that the goal is to create a national chart that could sit over top of, or at least fluent with the existing systems that are there, and building translation tables. Hopefully, things that can be automated so that over time, so that financial data could be extracted from these existing state-level systems and translated into the classification system and the chart of accounts that's developed nationally. A lot easier to say that than actually design and execute it, but I think that's one of the principles that we use.
I used to do cost reporting in home care, and they had a national format everyone had to follow. And when you looked at it and actually got the detail from who was reporting, everybody had a different interpretation of what went into what line. So unless you really have it really knotted down real tight so that everything's identified, you're still not going to get really good, clean information.
Apples to apples. Yeah, that's a big concern. And again, the devil's going to be in the details, I think, in terms of how that's operationalized. But certainly, detailed, clean specifications are going to be critical for a chart account like this to succeed in succeed in the goal of producing comparable cost data to support these kinds of
Just to add a follow-up comment that the National Mental Health Agency directors have done some work along this line, and they work in a similar kind of context as state health agencies. And higher education has done something along these lines, which has different kinds of systems and the like. So we think there's some models out there that can help us get to where we want to go.
So for the public health ROI demonstration calculator that you have out there, is it available now for you for some of their activities, kind of analysis on?
Yeah, I can just give a quick overview. We, through being one of the capacity building assistance partners in NIFI, National Public Health Improvement Initiative, we were seeing the need, as it's come up here today, for ROI. Hey, a lot of feedback. It's kind of bugging me. Try turning this off, if this helps. And so we put together a group of RWJ grantees under NIFI and secured the assistance of Glen Mays to really think through and become more informed of how ROI has been used, how it's being used in public health. And we're pointed to the need to develop a tool that would really help estimate the return on investment for the public health improvement initiatives, such as those undertaken through NIFI, and that those actually have the added benefit of being more modest, perhaps, because you didn't see these big health outcomes maybe impacted directly within the short time horizon, but that the benefits really could talk about the improvement health agencies were making in terms of a change, in terms of an outcome, and then monetizing that outcome, primarily in efficiencies realized, that sort of thing. And so we came up with this, these marching orders, and then Glen worked his magic in making a very complicated set of calculations embedded in a series of Excel spreadsheets. It also includes some issues around your initial investment costs don't have to be overcome in the first year. They can be amortized over the course of the project. So long story short, we beta tested it. And originally, for those who beta tested it, they said this is really a daunting tool. It's pretty hard to figure out. But once we kind of worked with them, they said, oh, okay, the lights are beginning to come on. And Glen kind of went through some of this in terms of increased outputs, increased efficiencies, different pathways for realizing a positive ROI. So the answer to your question, Myra, is we are in the process now of scheduling a series of webinars where we're going to roll this out early June. So it's right around the corner. I was just going to send an invitation email, as a matter of fact, to those who expressed an interest in it. And I'd be happy to include this group. And what we're going to have is a combination of myself and/or Glen kind of providing an overview of the tool and its functionality, and then those who are involved in beta testing kind of working through their examples live through a webinar, so you can see the data they input and how that translates to an ROI within the worksheets. And then the goal is to create an ongoing community of users, basically, who can support each other. ROI is a complicated endeavor, both in terms of thinking strategically about are you going to use this prospectively, where are you going to get the data, how are you going to talk people into giving you actual estimates of time spent on an improvement initiative. There's a lot of factors that need to go on into it at a lot of levels, and the tool itself is fairly complex with minimal instruction at this phase. So we want to create a community of users. But the concept came up last night at dinner. I mean, you all are already constantly seeing improvements in your agency being undertaken out of necessity. I mean, we don't live in an environment where you can just get away with doing business as usual. So if you are continuously improving anyway, this spreadsheet can sit alongside of that and have you input the data to show what you are doing on a daily basis out of necessity, how that's realizing a positive ROI, and can help begin to tell the story in monetary terms of what your achievements are. And it's hoped by kind of making this community of users that can kind of support each other moving forward, that we'll get down to a core group that can have some really good benefits coming out of this, kind of augment some of the other things that Glen is talking about that are ongoing at other levels. So that's kind of an overview. And what I will do is I'll send everyone in this group the calendar invites for those kickoff webinars, where we will be providing an overview of the tool and releasing the tool in its current form. The goal is also, I think Glen and I have talked about this, and folks at CDC that have become involved with this, some economists and some policy folks, is to create a tool that's really user-friendly. So it asks you maybe a series of prompts and it has you input data. And then it provides you a series of outcomes based on a number of assumptions. So you can see, if you're going to go with this level of investment, what types of benefits you can realize from your ROI versus another level of investment, which is really the concept behind ROI, is maximizing your return by looking at several scenarios. And I think plays well into the whole concept of QI, that you kind of want to do this in an iterative, ongoing process with this data alongside, kind of guiding where you're going and seeing the benefits as you go through the QI process. So I will send you a calendar invite. That's the bottom line. Any other questions? Okay, well, I've really enjoyed Glen's presentation and really appreciate his taking the time to be here and his leadership in this. So again, I'd like to recognize him for that.
Thank you. Please stand by.